Hello guys, welcome back to Medico Days. In this video, we'll be discussing about few of the questions which had come in the Neetpg in previous years of the subject ENT. So similar videos of other subjects will be also coming up soon. And guys, the PDF is available for sale of all the Neetpg PYQs along with the Inicet and the Fmge PYQs, the compilation book. And for today and tomorrow, we are extending the offer of 250 rupees for the mega compilation book. After that, the price will go back to the original one, that is the 750 rupees. So guys, if you are interested for getting the compilation book, do order it now itself because this is the last minute offer today and tomorrow, and then it will get over. And now quickly moving on to the first question. A 58-year-old male who is a known case of diabetes mellitus and hypertension presents with nasal bleeding. If the initial conservative management such as nasal packing was not successful in controlling the bleed, which artery should be importantly ligated to control the bleed? So out of the four options given here, the most appropriate option is the sphenopalatine artery, which is the primary arterial supply to the posterior nasal cavity. So mainly in people who are having hypertension, there is always a chance of posterior nasal bleeding than the anterior nasal bleeding. And since sphenopalatine artery is the primary arterial supply to the posterior nasal cavity and the main contributor also to the caudal plexus, that is where the anterior nasal bleeding most common site is the Little's area, that is the caudal plexus. So whether it is anterior or posterior nasal bleeding, sphenopalatine artery supplies both the areas. So that becomes the most appropriate answer. Persistent epistaxis, which is not controlled with nasal packing, is usually because of bleeding from this vessel. And so when we ligate the sphenopalatine artery, that will be the answer here. The caudal plexus, which it is, as the name says, it's a plexus. So it is formed by contributions from anterior ethmoidal, superior labial, septal branch of the sphenopalatine and the greater palatine arteries. So the names of these arteries are also important because sometimes question can come from there. That is, what are the contributors of the caudal plexus? So all the important things I have highlighted here, the highlighted black areas, you need to go through it. And then the anterior ethmoidal artery, it mainly supplies the anterior superior part of the septum. The posterior ethmoid artery, it rarely causes epistaxis, and so we usually don't ligate it. Greater palatine artery, it contributes minor blood supply to the septum. Okay, so appropriate answer here is sphenopalatine artery. Hierarchy of vessel ligation, as I told, sphenopalatine artery is the first and most important vessel to ligate. Then comes the internal maxillary artery. So greater palatine artery is a branch of this vessel, which is a part of the caudal plexus, as I told previously. Okay. Then the external carotid artery, then the anterior ethmoidal, and finally the posterior ethmoidal. So why is the sphenopalatine artery ligated first? Because it is accessed using a transnasal endoscope at the sphenopalatine foramen, and it is located at the posterior end of the middle turbinate. It supplies the posterior septum, which is the usual source of refractory epistaxis. And if again bleeding is persisting, then we go for the other arteries like the internal maxillary artery. Moving on to the next question. A 20-year-old patient presents with recurrent ear discharge and conductive hearing loss with 30 decibel hearing loss. Which of the following is the management of choice? So here, as you can see from the image, this is an image-based question. So nowadays, Neetpg is highly focused on image-based question, and here you can see that all the ossicles are intact in the image. So there is no need of ossicular reconstruction. So management of choice in this case is just myringoplasty, that is type 1 tympanoplasty, where we just treat the perforation. We are not going to do any ossicular reconstruction as ossicles are intact. Okay, so myringoplasty involves closure of the perforation in the pars tensa by placing a graft. There are two methods, either the underlay or the overlay method which is used. So common one is always the underlay method. Then common graft materials used are the temporalis fascia, which is the most commonly used. There are many reasons why temporalis fascia is used, because it can be accessed through the same incision, the William Weil's incision. So it can be accessed through the same incision, and then the thickness is similar to that of the normal tympanic membrane. The BMR is similar to that of the normal tympanic membrane. There are so many reasons why temporalis fascia is the best. So if you're not getting temporalis fascia, then the next option becomes areolar fascia, tracheal perichondrium, cartilage, vein, and periosteum. So underlay technique, the difference is that the graft is placed medial to the annulus, and in the overlay technique, it is placed lateral to the annulus. Moving on to the next question. An industrial worker presented with hearing loss, and the Renes was negative on the left side and positive on the right side. Weber's was lateralized to the left side, and PTA image is given. Again, PTA image is a very commonly asked question. So choose the most appropriate diagnosis. So Renes, which is negative on the left side, that means that the bone conduction is more than the air conduction. Okay, that is a case of conductive hearing loss in the left ear. And Weber's also lateralizes to the same side in case of conductive hearing loss. So whichever ear is affected, whichever ear is having the conductive hearing loss, Weber's will be lateralized to the same side. So again here Weber's is also lateralized to the left ear. And pure tone audiometry, it is showing that bone conduction is within the normal limits, but air conduction is elevated, meaning there is impaired transmission through the external or the middle ear. And here you can see that there is a gap between the air conduction and bone conduction, which is very clearly seen, and that is seen in case of conductive hearing loss. And so the tuning fork test along with the pure tone audiometry, it confirms left-sided conductive deafness. And these symbols which are used in PTA are also very, very important. Please go through that. So tuning fork test, Renes normal is Rene positive, that is air conduction more than bone conduction. And in case of sensory neural and normal hearing, it will be AC more than BC. In case of conductive hearing loss alone, it will be BC more than AC. And Weber's, it is heard in center in the normal people. In conductive, it will be lateralized to the affected ear. In sensory neural, it will be lateralized to the normal side. And ABC, so here it will be normal in case of conductive and normal people, whereas it will be reduced in sensory neural hearing loss. Then is the Schwabach's test. Schwabach's, it will be normal in normal people, and in conductive it will be lengthened, and sensory neural it will be shortened. So the difference between absolute bone conduction and Schwabach's is just that we'll be pressing over the tragus. In case of absolute bone conduction test, we'll be trying to close the EAC using the tragus, whereas in Schwabach's it will be left open. The test is done in this similar way. Okay. So that's it. Now moving on to the next question. So there are some important points again, like in otosclerosis, there will be the Carhart's notch, that is dip in the 2000 Hertz in the BZ curve. And in case of noise-induced hearing loss, there will be a dip which is seen at the 4000 Hertz. This again is very, very important. So PTA image, this will be seen. And in case of presbycusis, ototoxicity and noise-induced hearing loss, there will be a downsloping audiogram. In case of early stages of Meniere's disease, there will be an upsloping, that is an ascending audiogram. And a cookie bite audiogram, it is seen in congenital hearing loss and cochlear otosclerosis. So again, these are some of important points to be noted. Then moving on to the next question. A 75-year-old male smoker presented with complaints of hoarseness of voice and difficulty in swallowing. He is diagnosed with laryngeal carcinoma and undergoes surgery. What is the surgical procedure? So here you can see that there is a hole which is created in the over the neck. That is a permanent tracheal stoma, which is done in case of total laryngectomy, where the entire larynx is removed and trachea is brought out to the skin for breathing. It includes the removal of the larynx, hyoid bone, pre-epiglottic space, strap muscles, and often one or more rings of the trachea. The pharyngeal wall is reconstructed and a tracheal stump is sutured to the skin to allow respiration. So the main indications for total laryngectomy are T3 and T4 laryngeal cancers, or thyroid or cricoid cartilage invasion, and then bilateral arytenoid involvement or posterior commissure lesions, and in case of failure of radiotherapy or conservative surgery or transglottic tumors with cord fixation, it is contraindicated in case of distant metastasis. Then partial laryngectomy, it has an importance that it helps to preserve the voice, while tracheostomy is only for airway access and it does not remove the larynx. Moving on to the next question. A male child in his second decade presents with recurrent profuse nasal bleeding in the right nasal cavity and right nasal obstruction. So whenever a scenario is given like this, there is a child who is a male, usually a teenager, who comes with nasal bleeding, and usually sudden nasal bleeding, profuse nasal bleeding, always you should think about this. This is a very, very important, a very common question asked in multiple exams. So, presence with endoscopy shows a globular mass in the right nasal cavity occupying the posterior choana and nasopharynx. MRI shows the anterior bowing of the posterior wall of the maxillary sinus. Again, there is a name for this, is a particular sign which is seen in this condition. Again, there's a name for this. That is also very, very important. So this is a case of juvenile nasopharyngeal angiofibroma. Whenever there's a male adolescent with recurrent profuse epistaxis and unilateral nasal obstruction, always go in favor of juvenile nasopharyngeal angiofibroma. That is the most common answer which will be expected, and it's a benign condition, but it is locally invasive vascular tumor and it is testosterone dependent. And the MRI showing the anterior bowing of the posterior wall of the maxillary sinus, which is known as the antral sign or the Holman-Miller sign. It is pathognomonic of the JNA, that is a juvenile nasopharyngeal angiofibroma, and the tumor originates near the sphenopalatine foramen and can extend into the nasal cavity, nasopharynx, paranasal sinus, cheek, pterygopalatine fossa, and skull base. And biopsy is usually avoided because of the risk of profuse bleeding. Treatment is surgical excision. So this is the few features about that, and the treatment of choice is FIS, that is functional endoscopic sinus surgery. Moving on to the next question, identify the structure marked with white arrow. So here the image is a barium swallow study of the hypopharynx, and this corresponds to the area marked with white corresponds to piriform sinus, which lies on either side of the laryngeal inlet. This is a basic direct image based question. So now recently image based questions are coming up. Next, a 2-year-old child was brought to emergency department following choking on a peanut. The child was unresponsive. What is the next step for managing the condition? So this comes, this is a common thing which we learn in BLS as well, and it is a part of emergency medicine question as well as an ENT question. So here the answer is chest compressions. Whenever there is an unresponsive choking child, it is managed immediately by activating the emergency response system and beginning the CPR that is with 30 chest compressions. So it generates enough intrathoracic pressure to attempt to dislodge the obstructing foreign body while maintaining the circulatory support. Abdominal thrusts and back slabs, they are used only in conscious children with severe obstruction and not in unresponsive child. So after the compressions, the airway is opened and checked for any visible foreign body, and 2 rescue breaths are given, and if they fail and obstruction still persists, then CPR cycles should be continued. Next question, a boy sustained a fracture and an X-ray is taken. The lateral X-ray of the nasal bone shows a nasal bone fracture. Which forceps is used for immediate correction? So again, this is a very, very important question. Whenever there is a nasal bone fracture, and if it is displaced, then we go for a correction. Whenever there is an undisplaced nasal bone fracture, it is managed conservatively, it is okay. But whenever there is a displaced nasal bone fracture, we have to go for the surgery. So nasal bone reduction is done, and the forceps which is used for that is the Walsham's forceps. And there is a very common another forceps which people get confused with, that is the Ashes forceps. But Ashes forceps is not used for reduction. Walsham's is the one which is used. So Walsham, it is used for nasal bone fracture reduction. Ashes is used for reduction of the nasal septal fractures. So these are the image of Ashes, Walsham, forceps, and the other forceps as well.